And Sue, you can hear us okay, right? Like there's no...
I can.
Yeah, can you hear us fine?
Yeah.
Okay.
Perfect.
All right. Well, let's get started. And if anybody else joins, then it's all good. So welcome everybody to the third webinar from the Maternal Child Nursing Interest Group. We're really happy to have this series up and going. We're going to have some more topics in the new year. Today, I'm Susan Georgesis. I'm the current chair of the executive, and Erika is my policy and politics. I wrote it down here. Policy and political executive nursing officer for the group. So, and she's here with her partner Brittany, and they're going to talk about to freeze or not to freeze, talking about delayed childbearing and fertility preservation. I'm going to let you guys do the chatting. I'll keep an eye on the chat box, but I'll let Erika talk about how to manage questions. So.
Yes, and Sue, please interrupt us as needed.
Yes.
So if there's any kind of technical glitch, just let us know and we can stop.
Okay, just hold on one sec. Someone has said they can't hear. Now my mic is on and we can hear each other. So Linda, is there something on your screen that you can unmute? Just actually, can you try to speak to us? Sounds like a mic. Now there are other people present. I don't have your names in front of me. Is there anyone else that can't hear us at this point before we begin? Okay, I don't see any other comments. Oh, got it. Okay, she's good to go. All right, go ahead, Erika.
Awesome. All right, so hello everyone.
Hello.
We wanted to say thank you for having us today. We are very excited to share this topic with all of you, and we look forward to the discussions that we're going to have. So my name is Erika and I'm a registered nurse. I am also one of the executive members of the RNEO Maternal Child Nursing Interest Group, as Sue already mentioned. I work as a registered nurse currently on a birthing unit at a hospital in the GTA, and I am also one of the co-founders of Fertility For You.
Hi, everybody. My name is Brittany. I am also a registered nurse and currently work at a fertility clinic. I've been working in fertility for over 5 years. In 2019, Erika and I co-founded Fertility For You to bridge the gap between fertility clients and their clinic. We recognized that there was and still is a strong need within our community for support at home while going through fertility treatment. Care during fertility treatment goes far beyond just the clinic, and we hope to guide clients through it, holding their hand every step of the way. We do offer several nursing services, including consultations, injection administration, cycle monitoring support, and education. We would like to talk to you a little bit about our business and kind of like how we started. It's been quite the journey for us, and we started in 2019 and we're here now in 2020. Basically, we met at a fertility clinic in Newmarket, and it was actually quite funny. I was working, and Erika kind of just showed up. I didn't know she was a new employee, and she was waiting there for like 15 minutes. And eventually, the receptionist was like, "We have a new employee here." I'm like, "Okay, I'll bring her in. I'll start teaching her." And I had the chance and privilege to train her, and that was quite fun because her and I are very similar nurses. She's very eager to learn and has a very similar. Very caring, very compassionate. Yes.
And this was my very first nursing job. So of course, your first day showing up on the job and not having someone to greet you, like no HR or anything, I just felt so overwhelmed. But I remember seeing Brittany walk down the stairs and she had her nice lab coat on and she just looked so professional. I thought she was a doctor at first.
Yeah.
But no, she was one of the super dominating nurses on staff. But yeah, so that's how we started our relationship. She did a very good job training me. And here we are today, now starting this awesome business. So I wanted to talk a little bit too. So this is technically private healthcare. So being nurses that have worked within public healthcare systems, but then also in a private healthcare system, which is typically fertility treatment, it's actually been quite the navigation process. So we've had to learn just about what different processes you have to do for setting up a business. So setting up HST numbers, bank accounts, learning the independent practice scope for nurses, So the CNO actually has like a whole document telling us what we can and can't do as independent nurses, having our own practice. So going through all of that has been very, very challenging.
Yes.
So we wanted to take a moment. If any of you guys have questions just about independent nursing or starting a business, or maybe if some of you are also on this journey, if you have any questions or comments, we just want to open up the space right now if you wanted to ask us anything. So Sue, if anybody has asked questions, just let us know and we can answer.
Yeah. No?
I think she's just turning off her.
I just put on my mic.
Right.
I'll let you know what comes up.
Okay.
We'll wait like a minute, and if nobody asks any questions, we'll just keep going on today's content.
Yeah, but you know, how we started the business itself was, you know, both Erika and I were working together, and I kind of had the idea of helping clients more in the fertility clinic. I just noticed a need. I noticed there was a gap between the clinics and the clients. And I started talking to Erika about it and being like, there's got to be something that we can do. You know, why don't we partner up, you know, help the clients a little bit more? And that's kind of where we started our partnership. And we didn't actually, that was back in like July of 2018, right? Sometime around there, where we kind of started talking, and it wasn't until January of 2019 where we actually got the business started. So it's been quite the journey for us.
So Pradeepa has just asked a question. Hello, Erika and Brittany. I wanted to know, is it possible for an RN in general class nurses to start a business, or if you have to become an NP, a nurse practitioner?
No, so you can actually develop an independent practice as just a registered nurse. So you can actually look, if you go onto the CNO website, you can actually find their document. It's called Independent Nursing Practice. So it does talk about kind of what the rules are and what our scope ends up being when you are an independent practice nurse. And of course, none of this is covered by OHIP, so we don't get all the billing numbers. We don't really have to worry about prescribing or anything like that because that's not within our scope. So you have to be a bit creative of how you can actually work as an independent practice. So for example, for us, what we do is we actually provide injection administration. So the order has to be present in order for us to actually administer that medication, which the patient does get from their doctor. So at their fertility clinic, the doctor orders them that medication, and then they take that medication home and they have to administer it themselves. So we are still working with our scope without having to have an actual doctor working with us because the doctor's already prescribed the order to the patient. So therefore, what we do is we are just administering, which is within our scope. So it is quite challenging, and you have to be very, very careful when considering an independent practice because you do have to make sure you are practicing within your scope. Because I know a lot of time with like cosmetic injections and stuff, you do have to have a doctor prescribing those medications for you to be able to do it. So it has been a bit of a learning process for us too, of knowing what can and can't we do within our scope. Something too, like education, that's also a huge component of what we can do, and we know that is within our scope as nursing. So developing webinars and online programs, which we'll talk about later today, are all possibilities that you can actually sell it as a business.
Yeah.
Well, two brief comments. One is that there is another interest group through the RNAO, which is Nurses in Independent Practice. And it may be that we could hook up with them and do a seminar just on this topic. My own experience in independent practice is as a lactation consultant in the community. So any nurse who then has training in lactation consulting can offer those services in the community. But there's lots of things to think about. So it's a great topic we I think could explore as well. Okay. There's a thank you from Pradeepa. No other questions.
Oh, thank you. All right, thank you. So no other questions? No, okay, so we'll go on to today's content then. So Brittany, you can get started.
So learning outcomes. To start, we are going to discuss factors that may lead someone to choose delayed childbearing. Then we will present different fertility trends that are associated with age, outline the egg freezing process, and finally review the cost and funding available for fertility treatments.
Alrighty, so first off, let's consider the different reasons why someone may choose to delay childbearing. You may also have some reasons of your own that come to mind. So if you do, please share them with us on the comments section on the side or in the chat box. So a big factor is career paths and further education. Often our school and work environments make the lifestyle of childbearing very challenging. For example, childcare may not be available on site, or you may make less than what it would cost to put your child in daycare. School programs may not allow you to take maternity leave and come back where you left off. If you are just starting your career, you may not have enough hours to allow for a significant top-up for maternity leave, depending on your employer. You may also be single or are just not with who you would consider is the right partner to have children with. This makes half the equation difficult to obtain when trying to conceive. Finances may be a consideration, as we know it can be quite costly to have a child, including prices of food, clothing, education, extracurricular activities, healthcare costs that are not covered by OHIP, like dental, etc., just to name a few. You may not be in your ideal housing situation for childbearing. You may not have, or you may not feel that you are mature enough, or frankly, you just don't feel ready yet. And of course, our biggest reason slapping us all in the face right now is the pandemic. Is it safe to childbear right now? What will education look like in the future for my child? What effects will this have on my finances and ability to conceive? A lot of these answers are still unknown, and therefore it is up to us to figure out what level of risk we are comfortable with when choosing to conceive. Now, I want to start brainstorming how we can make work, school, and even societal environments more adaptive to childbearing. So that way delaying isn't our only option if we do choose to pursue these career paths or if we are stuck in a particular life stage. As healthcare providers and advocates for community change, that leaves a lot of work to be done.
Fertility trends. Unfortunately, as we age, so do our eggs. We typically say that 30 is the magic number because that is when our fertility begins to decrease for most women. At birth, we are allotted the number of eggs that we are ever going to carry, and this value is somewhere around 1 to 2 million. However, once we reach puberty, the number decreases to approximately 300,000. Of those 300,000 eggs, only about 500 of them will actually ovulate and be available for fertilization. So you can see how the numbers begin to decrease. This chart here depicts the rate of how fertility declines as we get older. And you can see how the decline gets worse once we reach the 30-year mark and continues to decline. Another important factor to consider is the rate of miscarriage. Miscarriage increases as well. So we have two things working against us. We not only have patients struggle to get pregnant, but also struggle to carry pregnancy to full term. This can be emotionally challenging for them and is a main concern when dealing with patients. One way that we support a pregnancy is monitoring their progesterone levels. Progesterone is an important hormone to help support a pregnancy, as its main role immediately after ovulating is to prepare the uterine lining for a possible pregnancy. We will often monitor the progesterone levels while also giving patients additional progesterone support, either vaginal suppositories or intramuscular oil injections. We normally provide this additional progesterone upon up until 10 weeks of pregnancy, since at that point the placenta takes over. This is the main way that we try to prevent miscarriage and support a pregnancy in the early stages. As a woman ages, not only do the quantity of eggs available decreases, but also the quality of them. So again, we have two things working against us. Not a good position to be in. There are ways to improve egg quality. There's diet, vitamins, exercise, reducing free radicals. Two supplements that we prescribe typically actually are CoQ10 and DHEA. CoQ10 is an antioxidant that research has shown can improve egg quality and pregnancy rates in women. It functions in the mitochondria to support energy production on the cellular level. It functions in the mitochondria, and ovulation is important in this process. Ovulation is an extensive process requiring an immense amount of energy that cells actually require CoQ10 for this process. The levels of CoQ10 decrease in our body as we age, so introducing it as a supplement has shown to improve egg quality. DHEA. DHEA is a type of hormone that has shown to improve follicular stimulation and estrogen production in women. DHEA is another hormone that declines as we age and therefore is prescribed to potentially help improve egg quality and the amount of eggs during stimulation. It normally has to be taken for 6 to 8 weeks for benefits to be seen. Unfortunately, we can't do anything about the quantity of eggs remaining. This is out of our control, so thus we try to improve egg quality.
So when it comes to ovarian reserve, there are actually 2 ways that we can determine a woman's ovarian reserve or reproductive potential. And that is by assessing their antral follicle count and testing for their anti-Müllerian hormone levels. So we'll talk about the AFC count first. So this is the total amount of follicles that we see in each ovary at the start of a menstrual cycle. It is measured by using a transvaginal ultrasound, and the technician counts how many small follicles, that's less than 10 millimeters, that are seen in each ovary. At the start of the cycle, we all begin with small follicles on each side. And in a typical cycle, only one of those small follicles actually grows and matures, eventually being ovulated. Generally, the more you have to start, the better. So especially in terms of fertility, because it means that we have more to work with to help reach a mature size. With that being said, the AFC count can give us an idea of ovarian reserve. The higher the count generally means that there are still eggs available. This count decreases as we age and thus is a marker to test our reproductive potential. So now that being said, with antral follicle counts, just because you have a high antral follicle count doesn't necessarily mean that all of your eggs are good quality or that there are even eggs in those follicles. So AFC may give us an indication of, yeah, we can definitely collect several follicles throughout your cycle, but what kind of egg quality is with it inside is a different story. So AMH, so anti-Müllerian hormone, this is a blood test that you'll have, and it's typically not covered by OHIP, so it's usually around $100 to $150. And it is a hormone that is produced by the granulosa cells in the small follicles in a woman's ovaries. And thus it acts as a marker for how many eggs she may have. AMH levels tend to be the highest at the age of 25 and begin to decline by the time we reach 30. So once again, that magic number. The higher AMH values usually signify that a woman has a normal ovarian reserve, and lower numbers may indicate that a woman has a low or diminished ovarian reserve. What this means for treatment is that they may not have much work to do when we have to stimulate growth. It can impact what types of treatment are recommended for the patient and the chances of pregnancy naturally versus trying to conceive through fertility treatment such as IVF. Once again, doesn't give us the quality of these eggs. It really only tells us how many or what potential you have for fertility treatment. So that being said, if you do decide to delay childbearing and considering what age alone does to your fertility, what treatment options are available to you right now in order to plan for your future? Fertility preservation. So the process of collecting and preserving your eggs for the future. So today we're going to break down this super complex treatment plan into 3 simple steps. 1, ovarian stimulation. Step 2, the egg retrieval. And then step 3, egg freezing and storage. So ovarian stimulation is the process where we use subcutaneous injections such as Gonal-f, Menopur, Retrieval, Leveris, etc. To stimulate your ovaries to produce multiple dominant follicles. The medications used act on your follicles within your ovaries to cause them to grow. It usually takes about 10 to 12 days of taking these medications in order to see the growth that we need before we can proceed with an egg retrieval. We are wanting to see the follicles reach somewhere between 18 to 22 millimeters. So if you think they start off at around 10 millimeter, we need them to grow quite large. Every clinic does have their own guidelines as to which size of the follicles are good for retrieval, but usually the range is 18 to 22. Ideally, we want more than just one dominant follicle to grow in this case, compared to your natural cycles where only one dominant follicle grows. So if we can get anywhere between 7 to 14 follicles by stimulating these ovaries, usually you're in a good position to go ahead with the egg retrieval. With ovarian stimulation comes multiple subcutaneous injections, early morning cycle monitoring appointments with blood work and transvaginal ultrasounds. Fertility treatment is always cycle dependent, so these monitoring appointments typically occur every 1 to 3 days from the beginning of your menstrual cycle, and that's in order to adapt the medication dosing and to time the egg retrieval. So if you can imagine, it can be quite difficult to manage these appointments when working, if you're in school, or if you have family commitments at home. If you look at our slide, you'll see on the left, so that is one of the medications that are used, Puragon, I think it is.
Yeah, it's good.
So a lot of our clients, they all are required to do these injections at home. Some of them will have their partners do it for them. Some of them will do them themselves. But you can imagine it's a lot of education and training that has to be given to these clients to be able to properly administer them and also change the dosing throughout their cycle. So of course, one of our services is to help with these administering, and it takes off so much pressure of having to make sure you're mixing your medications properly, you're turning the pen appropriately, you know how to change the cartridges, all that kind of stuff. And of course, they're administering these injections in the evening when their clinic has closed. So there isn't often a resource that people can reach out to saying, hey, I don't know if I'm doing this properly, or I think I just messed this up. How do I fix it? The second photo in the middle, you'll see, so that's an ovary, if you remember from anatomy class. So that's an ovary that has the growth cycle of one dominating follicle. So you'll see there's like 3 little ones that grow, and then you just have one that's chosen that ovulates, and then it shrivels up into the corpus luteum. So typically, like we said, in fertility treatment, we want multiple follicles to grow into that big dominating follicle. So if you look on the right, that's actually a transvaginal ultrasound picture that shows multiple dominant follicles almost ready for an egg retrieval. So they'll actually go ahead and retrieve those follicles. And you can imagine also how uncomfortable and how much bloating you would have if both of your ovaries were filled with like 14 follicles measuring 22 millimeters each.
And that's actually like a main concern with patients that are going through treatment, is the amount of bloating that they have, especially during IVF treatment. It's quite extensive.
So now the actual egg retrieval. So this is the process where we collect the eggs that have now grown within the follicles. And this is done through an operative procedure. So typically on the day of the retrieval, clients are put under conscious sedation. The physician will use a needle-guided transvaginal ultrasound probe, which you can see in the picture there. And that is to help find the ovaries with the many follicles with eggs inside. The needle will then be inserted alongside the ultrasound through the vaginal wall, which you can see there, and into each follicle, draining the fluid and egg inside each one. At the same time, you can see there's a little tube connected to that needle that goes into a test tube. That's actually brought into the lab where they start searching for all the microscopic eggs. So at the end of the procedure, clients will typically have an idea of how many eggs were retrieved and a general idea of their quality.
Egg freezing and storage. After the eggs are retrieved, the next step is to freeze the eggs, which is done through a vitrification process. The more eggs that are able to be retrieved, the better. The reason for this is because of rate of attrition. Even though there may be good sized follicles, it doesn't guarantee that there will be mature eggs in each of the follicles. So just to give you an example, we could have 20 mature follicles there. When they go to do the egg retrieval, maybe only 15 are actually retrieved. And of those 15, maybe only 10 of those are good quality eggs. Once it is established that they have the best quality eggs, they freeze and store them for later use. Now, once a patient is ready to use their frozen eggs, the eggs will have to be thawed and fertilized with sperm. Then they will have to monitor to see whether fertilization has occurred and watch as the embryos grow. Hopefully, there will be embryos that form from this process and are of good quality to transfer to the patient. This isn't a guarantee though, and rate of attrition applies here as well. So again, you might have 10 frozen eggs that are available. You go to mix them with the sperm, but maybe only like 5 good quality embryos are there. The patient will then, at that point, have to essentially undergo treatment to prepare the uterine lining for an embryo transfer. This involves taking estrase, a form of estrogen, for approximately 12 days to see the uterine lining thicken. Once the lining reaches a certain size, normally 7 millimeters or higher, then the patient will prepare the lining further with progesterone, and the transfer of the embryo will normally take place 5 days later. They will then continue taking estrase and progesterone throughout their entire pregnancy, well, until 12 weeks of pregnancy, I believe. Now let's talk about fertility preservation costs and funding. There are two options for patients wanting to undergo fertility preservation egg freezing. They can either pay out of pocket or they can wait for an IVF in vitro fertilization cycle. An IVF cycle, though, is different than egg freezing, and the Ontario Fertility Program only covers egg freezing if it's for medical reasons, cancer diagnosis being the main reason. The Ontario Fertility Program does cover the costs for an IVF procedure. However, the wait times for this are quite long and vary depending on the clinic. IVF is different. This process takes things one step further and fertilizes the eggs with sperm to produce viable embryos. If you're wanting to just freeze your eggs, you will have to pay out of pocket. Egg freezing costs vary depending on the clinic, but generally patients are looking at around 5 to 8K. This does not include medication costs, and the cost for medication can range up to 5K as well. So you can see how the cost of fertility medication and the procedures can be quite high.
Mm-hmm. So we wanted to leave lots of time for questions because we didn't think we had time today to really go through in extensive detail all of the medications, the different protocols you can be put on, and other factors affecting your fertility. We do have an online program that we do have that is available for clients to take. So it's very similar to what a prenatal class that you would take for pregnancy, just because it's quite overwhelming when you're about to go through fertility treatment and you have absolutely no idea what you're about to get yourself into. So one of the things that we do offer also with our business is an online program that just prepares people for what's all involved and just provides that extra support and education for what they're about to get into. And I think also we sent out earlier that you can follow us on Instagram. We're always posting really fun education materials, and we're always like willing to engage with different clients. So you can always check us out on Instagram.
Yeah.
And then also our website as well. We do post all our services there. Our education part really isn't on the website though. If you want to have fun and really engage, that's more on the Instagram.
Yes, join our Instagram. That's where the fun is at.
So Susan, we did leave a lot of time for questions. So I'm hoping everybody has lots for us.
Well, there's actually nothing on my chat box at the moment. So I'm going to start and then perhaps there will be more.
Yes.
I guess one of the things that went through my mind when you were talking about ovarian stimulation and the medications and even the discomfort, like the impact on your body, are there risks to this?
Yeah.
Are there impacts on other systems in your body?
Yes. So there's actually a condition called ovarian hyperstimulation syndrome, or OHSS. This is something that we monitor for, especially when someone's going through IVF treatment. Essentially, it's fluid overload in the body. When you're having that many follicles grow, you're expecting to have a lot of fluid as well. And so the biggest risk would start being bloating. If patients are having a lot of bloating, a lot of abdominal discomfort. If it gets worse, it can actually get to the point where they're having trouble breathing. Now, I haven't seen a case personally where OHSS has reached to that point because we monitor patients very closely so that it's preventing. But I'd say that's the biggest risk is OHSS.
And we monitor not only the follicle size, but we're actually monitoring estrogen as well.
Yeah.
So estrogen, that hormone, if it skyrockets too high, can actually cause that fluid imbalance within your body. Which can be quite severe, as we all know, and you can actually be hospitalized for it. But yeah, like Brittany said, we monitor so closely that very, very rarely does that actually happen. And sometimes cycles are actually canceled if we think OHSS may be more severe. There's also some medications that we can put people on after their egg retrieval to reduce some of that fluid overload happening. But most often, if there's too many follicles that we think it's dangerous, the doctor will usually cancel the cycle.
Or alternatively, there's different types of triggers for the egg retrieval. There's normally ACG or Lupron. Lupron is the option in that case. If they're noticing that the estrogen levels are too high, they'll give Lupron, and that actually helps bring down the levels. And as well in that case, they don't always go for an embryo transfer right away. So in an IVF treatment, they'll mix the egg with the sperm, and 5 days later they'd have an embryo transfer. But if they're at risk of OHSS, they won't do the transfer. They'll freeze the embryos instead.
And wait and do it at a later time.
Exactly, they'll do a frozen embryo transfer.
So this is a question about if I was.
And we did talk.
Oh, go ahead. Sorry, there's a little bit of lag in our,
Sorry, I think
our audio. Do you want me to go ahead? Is that or do you want
okay. I was just gonna say, I'll go ahead. I'm just gonna start talking.
Okay. Yeah.
So some of the terms we were just using there, like the Lupron shot or the HCG shot, we didn't really go into too much about medications, but typically with an IVF cycle or for fertility preservation cycle, there is what we call a trigger shot. So basically leading up to allowing your follicles to grow, you're taking all of these stimulation medications. So these are the medications that are causing your follicles to grow and develop. When it comes close to where we have like the amount of follicles that we want, they're all around the right size, that's when we give the trigger shot. So it's a one-time dose that is given subcutaneously, and that one's actually timed very appropriately as to when the physician wants to do the egg retrieval. So when that shot is given, usually it's 24 to 36 hours, depending on how the clinic works, that your egg retrieval is scheduled. So when she was talking about like that Lupron injection or HCG injection, that's the trigger shot. So sometimes you can give a trigger shot that will kind of not stimulate as much when it comes to OHSS.
Okay. I was just imagining if I was paying for egg retrieval, I've invested, sounds like $10,000. And and then what if they just like cut it off because they feel like I'm responding, you know, or at risk of hyperstimulation. So I just am curious as to how often that happens. It didn't sound like you had seen it happen in your clinic. Do you know what the rate might be?
I don't know the rates of like how often that happens. It does happen where they do get canceled. And it's unfortunate because they can't be reimbursed for the medication costs. That's, I think, the biggest price at that point. As long as they don't go for the egg retrieval itself, they don't get charged for that procedure, but it's the medication costs. And so they've probably spent 5K or $5,000 for medications, you know, we can't do anything about. But it does happen, unfortunately.
And even like if we were doing an IVF cycle, so we didn't really talk too much about IVF today either, but the government actually has a program, the Ontario Fertility Program, which we talked a bit about today. They do cover fertility preservation for medical conditions. So like we talked about, if you're about to go through chemotherapy, we know that chemotherapy can destroy your eggs. So in an attempt to try to preserve your fertility, you do the fertility preservation. So it will cover those types of cycles, but it also covers one IVF cycle per person in their lifetime. So that's anybody, whether you have a medical condition or not, which is quite impressive for our government. We're actually the only province that is doing that right now, I think, unless, or is it PEI that does it? There's one other province that does it, but like that's unheard of, the fact that Ontario does it. And I believe it was 2 years ago I read that they actually gave $50 million worth to Ontario residents to fertility treatment,
for sure.
which is insane. But of course, it's very frustrating because that does limit how many people can do an IVF treatment kind of at a certain time. So often when you get onto these waiting lists, they can be up to a year, sometimes even longer, and it all depends on the funding. And there's also lots of restrictions too, in terms of age. You have to have an OHIP card. And then there's restrictions even once you get the cycle started. So like you can only have 2 cycle cancellations, which happens sometimes when you go through fertility treatment. When you have infertility issues, you may not get enough follicles. You may even end up an entire cycle and not get any embryos. So that can also be very devastating when you've been anticipating for this one cycle that you have full coverage for, I mean, not including medications, but, and then to find out that your outcome was 0, or that you had to cancel twice, and maybe then you didn't even have the opportunity for an egg retrieval, it can be quite devastating.
And there's no, unfortunately, once they go through that process and go for the egg retrieval, if they end up with no embryos at the very end, then that's their cycle. They don't get a second try. When it comes to funding, of course, they can pay out of pocket, but funding wise, that's it.
So, and a lot of time we do try, and when I say we not as me and Brittany, but like clinics, they do try to really figure out like what your ovarian reserve is by doing those testing. So like the AFC counts, the EMH, and there's several other tests that are done to try to figure out how successful will you be, and do we need to go all out on all these medications, or do you need only maybe a little bit of stimulation? They really try to evaluate how they think your body is going to respond, obviously to make so that you only have to do it once. That being said, though, it is a lot of trial and error. So sometimes your body just does not respond to certain medications, right. And that actually changes from cycle to cycle. Right. So your body may respond beautifully one month, and then the next month it may not. So it really depends on the person, it depends on your cycle, and even the medications as well.
I want to just, I'm assuming that people who have joined the session today are interested in the, your topic specifically about whether or not to freeze eggs. Do you have any sense of how much more common this is for young women to make the decision to freeze their eggs so that they can delay childbearing? Any numbers at all? Does anybody keep track of that?
We don't really keep track of it. I've actually only seen it like once or twice. It's not very common. And I think it's not very common maybe because people don't realize that it's an option. And then there is the price point to it, is that it is expensive. So, people, they don't think about it in their mid-20s about their fertility. And
can't afford it.
In their 35. Right. And can't afford it in their mid-20s, right? We're planning on trying, getting a career going, buying a home. The idea of fertility preservation at that point isn't really on our minds. Mm-hmm. I personally have actually thought of it myself, but personally, cost is a factor. So I haven't seen it too often, but I have seen it, and the times that I have seen it, it's been because of career reasons. Mm-hmm. Is that if they weren't able to because their current career doesn't allow them to, so they
right.
And so it's an interesting topic too. I mean, we can probably discuss a little bit about this, but whether we think that our government should be providing some funding for these situations, right? Because you get put into a corner of, well, I'm not in the right lifestyle, or I don't have a partner, or I can't afford all of this stuff now, but then I can't afford also to preserve my fertility. So you're kind of put into this corner of like, well, what do I do? And so that's why really at the beginning of the webinar, we wanted to stimulate discussion about how can we actually change our society so that childbearing doesn't always have to be delayed. So we often have this idea as a society that, well, if you're going to become, for example, a doctor, you've got your 4 years of undergrad, then you got to go to medical school for 4 years, and then however many years of residency. How do you plan to have a child in the middle of that, right? And then all the debt that you're in as well. So how can we make it so that it's not as hard to make that decision to childbear? How can we make work environments that it's not so hard, right, to get maternity leave and all that sort of stuff? So rather than kind of a secondary approach, we think of it more as primary thinking of, rather than having to pay all this money afterward to help these women preserve their fertility, or now who are going through fertility treatment because you're past the age of 30 or 35, how can we put things in place earlier so that people are well educated and understand that your fertility does decrease?
Mm-hmm. Are there particular resources that you might recommend to anybody in the session that would help them learn more about this? I don't know if there are books or websites. You mentioned some supplements that are used in some of the care around fertility. Is this something people should be thinking about before? Like, I don't know if it makes a difference to take some of the supplements, like the DHEO, is that right? Or is it something you just sorry, I tried to scribble it down. Is that something you should be doing with vitamins, or probiotics, or is it something you would do in the year before you're wanting to attempt childbearing? I asked you 3 questions there.
I think it would be beneficial to start some, we tell patients to start prenatal vitamins right away. With CoQ10, I feel like that's a beneficial supplement to start, especially even if you're thinking to yourself, I might have a kid when I'm in my early 30s and you're 28, 29, it might be a good idea to start introducing things like that at that stage. DHEA is something that gets more introduced by the doctor, and is normally after they've tried several cycles and they've proven that their AMH is low, that's when that gets introduced.
Mm-hmm.
So,
and even lifestyle factors. So things to consider. Something that a lot of people don't realize is smoking cannabis or even ingesting cannabis can destroy your egg quality. It also destroys sperm quality, and we see it makes under the microscope, you can see the sperm start swimming in circles rather than trying to swim up.
Wow.
Fortunately though, I mean, men, their sperm can regenerate every 3 months, right? So that's an advantage. Whereas our egg quality, that's all we have for our lifetime. So if we ruin that quality, there's really no going back. That not to scare anybody who's maybe had cannabis or that's not to say that your eggs are completely destroyed. But just to keep that in mind, if that's something that you need to change, if you're thinking, in the future, I really do want to have kids, changing those things, like smoking weed is a big thing that you can take out of your life. We also do always connect our clients to naturopathic doctors. We always, we're big believers in holistic care. So we think you should have a really good team of people that are pouring into your fertility treatment. So going with a fertility clinic on its own can be great, super helpful, but also having a naturopath added into that, they can provide acupuncture care. They can really specialize in knowing what your body needs nutrient-wise, supplement-wise, and even lifestyle changes. There's lots of online courses you can take too that kind of go over all that kind of stuff. But usually that's what we connect as well as with a naturopathic doctor.
Okay, that's really interesting, because I was going to ask you specifically about online resources or classes, but Nina has just asked, as a nursing student interested in working in fertility, are there extra courses or certificates that you would recommend taking?
So
unfortunately,
there isn't
there isn't
a specialty course. Fertility is it's relatively new. I mean, I think the first IVF that was ever conceived, it was 40 years ago. Yeah. So it's still a fairly new area of nursing. So unfortunately, there aren't really regulated courses that you can take like you would for perinatal care, like how you can take a perinatal course at Humber. So there aren't really colleges that offer that kind of education. I know some of the drug companies do offer some more online webinar type things where you just kind of go through modules. But that being said, sometimes they're really dry and it's hard to understand. There is also the CFAS, which is the Canadian Fertility and Andrology Society. There we go. So you can become a member of that. So that's it's kind of similar to the RNAO, but it's for specifically anybody who works in the fertility field. So that includes lab techs, doctors, everybody. And you can actually become a member. It's quite expensive, but they have lots of educational webinars. I think there is a kind of a certification with assisted reproductive technology. So that's something you can look into.
Can you repeat
and then of course
again?
We have
just tell me the name again. I'm going to put it in the chat box. Canadian.
So it's the Canadian Fertility. And Andrology Society.
Andrology Society. Okay, thank you.
So they have conferences, lots of webinars that you can attend, and even previous ones in the past that you can watch as well. So that's a really great resource if you're trying to expand your knowledge. In terms of actually getting a job in fertility, I know for me, I kind of just lucked out. I had a placement during my community year where I got placed at a fertility clinic, and that I mean, before then, I didn't even know fertility clinics existed.
Yeah, neither did I.
I had no idea that was an area of nursing that you could go into. So I kind of lucked out, and then that's how I managed to get my first job. But if you are looking into getting in fertility, definitely try to expand some of your knowledge base. If you do have backgrounds in maternal child care, I think that is definitely a a resource to you, just because there is a lot of pelvic exams that go on. Like we've performed IUIs.
Yep.
So that's, you go in and you put in a speculum, you take a little catheter and it goes through the cervix. So knowing the anatomy and understanding like cervical discharge and all that kind of stuff is super, super helpful. And even just how to talk to people who maybe have experienced losses. I know for us, like many times, like we're the ones that have to tell somebody that on their ultrasound that there was no heartbeat.
Yeah.
So that has been something that was really, really challenging. And as somebody, as I was brand new to nursing, I had no idea that that was part of my role. To then have to say over the phone, by the way, your ultrasound results today came back and there was no heartbeat. This is what you should be expecting. So having that experience with loss, especially in maternal child care, I think is super, super valuable when trying to get into fertility. And I don't know if you want to elaborate on that, Brittany.
No, it's, I agree there. There's not a whole lot I can add to that, but having that experience, a lot of fertility clinics will say that if you have counseling experience, that'd be great because of that reason. And, you know, having experience in maternal nursing is a plus for sure. Yeah.
And for those of you, like if you kind of want to know what the role of a nurse is at a fertility clinic, so there's many different roles you can have. So basically how a typical clinic will work, you have a cycle monitoring nurse. So this is somebody who actually evaluates all the different blood work and ultrasound results in the morning. And then either by following medical directives or by receiving like orders from a physician, you give the patient next steps. So whether that's, yep, tonight you're going to inject Gonal-F at this dose, or actually you're going to increase to another dose. Come back today because we got to sell you another medication that you're going to start, or even like just kind of explaining all of the ultrasound results and what they mean. So that's kind of one big role within the fertility clinic. There is also, I guess you could say like the operating room nurse.
Yes, the OR nurse.
Yeah, the OR nurse. So that's somebody who would be in charge of all the egg retrieval processes. So you have to do the preoperative, intraoperative, and postoperative roles. And you do typically have to have your ACLS because most fertility clinics don't have an anesthesiologist on site. And you yourself are pushing medications like fentanyl and midazolam. So you got to kind of know if something goes wrong, what to do.